All right, so welcome everybody to panel E, Make Your Research Count, Learning from Health Systems, What is Useful and What They Need. My name is Beth Mansfield, and I am here from Health Canada today. I'm the social science lead in the Knowledge Translation and Exchange team in the Nutrition Regulations and Standards Division, which is part of the Bureau of Nutritional Sciences in the Food Directorate of the Health Products and Food Branch of Health Canada. So welcome to today. We're really glad that you're here. Just to maybe preface what we're going to be talking about today, I'd like to come back to the central focus of Healthy People 2030, which is health literacy. And one of the initiative's overarching goals really demonstrates this focus on eliminating health disparities, achieving health equity, and attaining health literacy to improve the health and well-being of all. And Healthy People 2030 really addresses both personal health literacy and organizational health literacy, and actually provides the following definitions. And these two different definitions taken together constitute health literacy. So personal health literacy, as you're all very well aware of, is the degree to which individuals have the ability to find and understand and use information and services to inform their health-related decisions and the actions they make for themselves and others. Organizational health literacy is really the degree to which organizations equitably enable individuals to find and understand and use information and services to inform health-related decisions and actions for themselves and others. These definitions together emphasize people's ability to use health information rather than just understand it. And these definitions focus on the ability to make well-informed decisions rather than appropriate ones. And these definitions actually incorporate a public health perspective. For today, we're really focusing on how these definitions also acknowledge that organizations have a responsibility to address health literacy, that personal health literacy is contextual, and that producers of health information and services have a role in improving health literacy. And the definition also emphasizes organizations' responsibility to equitably address health literacy. So in this panel discussion today, we will discuss the value and importance of making progress in the implementation and evaluation of health literacy-based strategies in health systems, organizations, in health policies and research, as well as regulations and communications. Our four panelists today will give brief overviews of the types of research findings that could motivate, promote, advocate for mainstreaming health literacy as an organizational and societal asset, building on systems thinking. So I'm really happy today and have the pleasure to introduce our four speakers, Barry Weiss, Marianne Abrams, myself, and Christine Sorensen. And to get us started, Barry will be the first speaker, and he actually has a couple of interactive tools that he will be using in his presentation. So first, Barry, why don't you introduce yourself, and then I will let people get involved in the first question that you have for everybody.
Okay, well, I'm like it says on the slide there. I'm Barry Weiss. I'm from at the University of Arizona in Tucson, and I'm a long-term health literacy guy. And you know, one of the things we'd like to accomplish today is to have a lot of interactivity with all of you who are attending, and not just have us talking at you. So you know, we have not planned an hour and a half of talking to you. And so hopefully we'll have some good chatting and even some outright speaking. But one of the things I wanted to talk about in my little brief introduction is the issue of what are we doing with health literacy research these days? And to start that, we put together a little, I think it's one question with 5 multiple choice options. So over the past several years, what has most published research on health literacy been about? And this will set the stage for the things we're going to talk about today. So how about you all look through, these are the possibilities for, you know, what is most of the literature on health literacy been about, and see if you know the right answer to this. Is it, I don't know if you can see my arrow here. You know, is it the first one is assessing how medical outcomes are influenced by the health literacy skills of patients? Is most of the papers been about measuring the health literacy skills of different patient populations? Has most of the literature been on measuring readability or understanding of patient education materials? Has it been on developing new health literacy instruments? Or has it been about measuring health literacy outcomes after health systems make change to make them more health literacy friendly? So what do you think has been most of the research in health literacy over the last couple of years?
And just a note for everybody, you can join at slido.com on your computer or your smartphone, put in the hashtag number, and then it will show you those questions and you can put in your answers. So we'll wait for everybody to go through and do that, because we know that, you know, we've got over 30 some odd people here. So you can see on the top that 9 of you have answered. So we'll wait a bit of time to give you all a chance to review and put in your answer. Thanks so much.
Beth, can you scroll that so that everybody can see the very last answer? Or,
there we go.
oh, then you can't see the top answer.
Yeah.
And, you know, and again, this is a lot about what we're going to be talking about today is where are we going with health literacy research? What's the stuff we're doing? What's the stuff we should be doing?
So I got about a few more people still thinking about their choice. And just a note to everybody, there is the chat and the Q&A. If you have any questions as we go through, you'd like to add a comment, you have something you'd like to chat about, certainly you can take advantage of that as well throughout this discussion today.
Yeah, I'm seeing now there's 53 participants. So we got responses from about half of the people so far.
Yeah, we'll take another little minute just to see. Sometimes people have to take the time to get on to the Slido. All right, Barry, I'll move that up for you so you can see the bottom percentage, just so you can make your feedback here.
So most people think, what's up on the top? Most people think that a lot of the research is about whether health literacy influences medical outcomes. You know, and then, okay. So is everybody done? Raise your hand if you're not done. Yeah. Right. Well, I think we can go on from there. So let me go. I'll show you the answers, the real answers. You know, I'm pushing that advanced slide thing. Yeah. Okay. This is what. You know, I get from PubMed a report every week on what's the stuff that's been published on health literacy, and I've been doing that, looking at that for years. You know, several years ago, I published a paper that looked at like a 1-year archive of what was all the research about. For this presentation today, I just took a couple of the weekly reports that came in the middle of last month and looked at what was the research about that's still being published. And it's the same old stuff. You know, the most common thing we see is, you know, yeah, people with poor health literacy have worse health outcomes. Now, I think we knew that like 25 years ago, but that's what people are still studying today. You know, there's lots of papers coming out on whether on patient info, you know, handouts for patients and websites for patients is easy to understand by patients. We've known for 25 years that the stuff that everybody gives patients to read isn't understandable, but people are still doing research on that. Measuring health literacy of patient populations, finding out that lots of people have poor health literacy. We've known for 25 years that that's the case, but we're still doing research on that. Creating more, I was one of the people who created the newest vital sign health literacy assessment instrument, but we did that was probably 20 years ago, but new ones are being created every week. They're on PubMed, but the real important stuff about how to educate patients effectively and how to create health organizations that are health literacy friendly, that's where hardly any research is being done, even though that's what needs to really happen. And all this other stuff above it, we've known for decades. And let me go to the next slide. So the question is, do we need more research like this? And I just pulled a few examples of what was in that PubMed report back last month. We're going to look at the impact of low health literacy on patient health outcomes. Okay, I guess, that's not ground shaking research. And we've known this for decades, and yet we're still seeing studies on this. How about this one? How readable is orthognathic surgery consent forms? Now, I have no idea what orthognathic surgery is, but apparently the consent forms are difficult for patients to understand. And again, we've known for decades that the consent forms and other handouts are difficult to understand, but people are still doing research on this. How about this one? Readability of online patient education materials, finding out that they're hard to understand. Oh, okay. We've known that for decades. Everybody's doing stuff that we already know. Development and validation of the Minnesota Assessment of Pharmacogenomic Literacy, creating a special health literacy assessment for that. Why are we doing all this stuff over and over and over? I worried a little bit that maybe somebody who signed on to the session was involved with one of these. So let me share with you that we all do it, even me. I was approached last year by one of my urology colleagues at the medical school who said, I want to see if the educational material that's out there on kidney stones is something that patients can understand. And I sort of said to him, we have 1 million studies showing that this stuff is not understandable. Why do we need to do this? But he wanted to do it, and I signed on and I helped. So, I'm part of this too, doing studies about things that we already know. Now, interestingly, it turned out this paper was the most widely read paper in the urology journal that year, because the urologists didn't know about this. So there is some value to doing that same old research over and over, because not everybody in all the different fields of health professions knows about it. But, again, it's not the most important research because we already know it. And again, we all do it. Here's from our Health Literacy Research and Practice Journal, which is the journal in health literacy. Here were 2 papers that were in last month's issue. Validation of a method to assess health literacy in adults in Samoa, or on the bottom of the page, the psychometric properties of a health literacy scale for workers in the automotive metal sheet factory in Iran. Now I guess maybe the people in Iran are just catching on to health literacy issues, and so this is an eye opener for them. But for the general field of health literacy, none of this stuff is really eye-opening research. We need to be, moving on to things that we don't really know. So basically, isn't there something better we can do? And that's what I really want to focus on today. Is where could we be taking our research in health literacy besides making new health literacy assessment instruments and measuring that people don't have good health literacy and that handouts are hard to understand? Isn't there something better we can do?
And just for participants to know, this is the next Slido question. We'd like you to go in and just fill in, a word about what you think is something better we can do, or a phrase, I should say. And we'll leave you some time to really think and reflect and put your feedback in there. Thanks so much, everybody.
And actually this comment in the chat, clinicians and healthcare team members don't recognize health literacy outside of us. And I agree with that. That's why that paper in the urology journal, I thought, come on, everybody knows that the handouts about kidney stones are going to be hard to understand, but it was an eye opener for the urologist. So it's not like that kind of research shouldn't be done because it is eye openers for people in other fields. But if we want to move the field in a forward direction, we need to be doing something besides the same stuff. You know? Oh, I like that one. How can we help people feel more comfortable asking questions? The question is, how can we?
Yeah, share the educational resource that was developed. That would help, wouldn't it? Wow, this is getting people thinking.
Yeah. No, this might, let's save this slide. This could make a nice
Oh,
little
it's all
paper,
saved.
a nice
It's
little
all
paper in
saved.
health literacy research and
worry.
practice on what people think we should be doing for research.
Yeah.
Right, yeah, and like Christine's saying, yeah, we see some of these same studies now are appearing all over the world as people are getting turned on to the health literacy issue. So again, there's nothing wrong with that, but we also need to do new stuff. Addressing health literacy in secondary education curriculum. I did some work with the adult education program up in Anchorage, Alaska. And this was a program for, it was mostly refugees and immigrants. Most people don't know Anchorage has the most diverse population in the United States, with a huge 90 different languages are spoken in the Anchorage school district. You know, and lots of people are coming there from other parts of the world as refugees and need to learn to speak English. The health literacy program, or the adult education program there, decided, how are we going to teach people to speak English? And they decided, if we teach in the context of health issues, that will be way more interesting to patients, or to the enrollees in the adult education program. And so instead of teaching them to read Dick and Jane and walking the dog, they taught them how to speak English about health issues. And it turned out to be really, really engaging because people really wanted to know about health stuff. And so, yeah, that can work. These are all really good ideas. Yeah. We're gonna have to take these and just gonna categorize them into groups, and it could maybe set a, what does everybody think health literacy research should do? And it looks like we're kind of maxing out on the list. Beth, you'll be able to save this list, right?
Yeah, I'm just trying to make sure I figure out how to do that.
Well, it's going to be recorded, so it'll be there. Right, top down. Yeah. Yeah, I did a workshop for a state hospital association earlier this year, and they were really into that. If you get the CEO turned on to health literacy, everything changes. If you just have the frontline staff interested in this, it's really hard to make the system change.
Hey Barry, on the chat bar, there's a little ... and you can just save the chat if you want.
Okay, so we can save the chat as well.
Yeah, that's a much easier function if that's what you're looking to do. Yeah.
Yeah, but no, we also want to save this slide with all the.
Sure.
Yeah. All right, I think we've kind of maxed out, Beth. We probably can.
Yeah, you can move. Let's just see.
Hey, Mario, do you have to hit those 3 dots every so often to update the save, or is it one-time activate saving the chat?
You would want to do that at the end of the session to save the
Okay.
chat.
Okay.
Okay. Okay, well, thanks so much for that, that first section of our discussion today. I'd like to introduce Marianne Abrams, who's with us here from Ohio State. Marianne.
Hi, everybody. Thank you, Beth and Barry, for a great introduction to this session. My name is Marianne Abrams. I'm an assistant professor in Department of Pediatrics at The Ohio State University and the College of Medicine there. Like Barry, I've been working in the field for quite a while. I did quite a bit of work in Iowa, and now I'm trying to build that and continue that work in Ohio. And again, I really like to focus on how health literacy is cross-cutting and integral to all dimensions of health, whether it's public health or clinical health, end-of-life care, preventive, therapeutic, et cetera. And to really help illustrate how it is fundamental to quality and safety, patient experience. And those things, I think, bubbled up a little bit in that previous Slido question, as well as I try to focus on tools, resources, trainings that connect the real world setting with, I think what a couple of the comments also said, sort of the research realm. So hopefully, as we transition to the second part of our session, we'll sort of maybe think about how do we apply what Barry just said and what you all were talking about and sharing in that previous Slido question. I'm not advancing here. Do I click that little arrow or do you do it, Beth?
I can do it if you want.
Oh, I just did it. Okay, so I'm looking at the slides and I'm looking at Barry in Alaska and I'm looking at Beth and her horse. And I was like, well, I go outside too. So I wanted to replace my nice headshot with an illustration. Over the weekend, we were able to go to the Cincinnati Bengals game. And after the game, we got to go down in the field. So that's my daughter and I playing a game of football. There weren't any Bengals still on the field, but thought it was kind of a fun way to spend the afternoon. And they won. So anyway, back to health literacy, right? We just talked about what you see as the biggest health literacy issue in your organization, and a couple things came across to me. I think Barry highlighted a lot of those as they were going by, but there was a fair amount of thought given to the concept of training and education, which is very important because it's different. A lot of people think they're using health literacy skills when in fact they aren't. I mean, they care deeply and they're trying hard to teach patients and families, but they're not necessarily focusing on plain language. They're not using shared decision-making skills, as our previous keynote this morning talked about, and not making sure at the end of the day that people understand with teach back and all the other things that we know are effective. So training necessary, probably not just sufficient. I saw a lot of things go by that talked about practical things and application in the real world. So as I'm kind of summarizing that, use this question to kind of bring home what we were just talking about with respect to your organization. So I'll keep kind of talking as people type in the answers to this question, and buy-in and support from leadership was identified earlier and again is identified here. Yeah, we're all dealing with nursing and other staff shortages, but I would argue that if health literacy becomes part of the culture, just like quality and safety, we work very hard to overcome these shortages to make sure that we provide good, high quality, safe care. We need to have health literacy skills be part of that care and just be part of the way we operate. So what else do we see here? Physicians are an issue, hopefully a good one. Resistance, we'll talk about that in a little bit. Change, it's always hard to change things. Leadership, dissemination, policies not being disseminated and implemented. Sustainable, I think that's a really important point. Resources. Students being exposed to the concepts, but not practicing them. I think that's a really important point because they may learn it and there's more and more training in the health profession schools, but then they don't see it when they're shadowing or on rotations or being trained, and it's not being role modeled. Dissemination, knowledge, understanding the breadth and width. So resistance seems to be carrying the day. Do we give it another minute, Beth, or do you think we've topped out there?
I think that's good. Looks like everybody's put in.
17 people have tapped in or typed in.
Oh, someone's still typing.
Okay. Consistency and handoffs, that's an application opportunity, right? For health literacy, making sure we're clear that we're using teach back, we're raising concerns about whether the patient or family may understand well and that we communicate clearly. When my screen's going dark, is that a function of a screenshot?
No, that was me trying to screenshot.
Okay, that's fine. First I thought, oh no, I'm past losing it. All right, why don't we go on to the next slide? I guess I can do that. Maybe.
There you go.
Great. So I think in terms of where to start on this, we have good evidence. We have good research. Some of it is still evolving in terms of the effectiveness, which is, I think, one of the points that Barry was trying to point out. And we have from the Institute of Medicine Roundtable on Health Literacy, these 10 attributes of a health literate organization. And anyone who is interested in starting this work, I really, if you're not already familiar with these, really encourage you to take a look at them and to guide it, kind of get a sense of what does each of these attributes look like for your health entity, whether you are a clinic, a dental office, a public health department, a community-based health-related organization, or a big health system. And you do have to have investment of leadership, but then the question becomes, how do you do that? And we talked a little bit about the return on investment. We talked about the relationship with quality and safety. And one thing I didn't see percolate up in either of those lists that we just generated is the importance of health literacy to health equity. And that was highlighted in that Healthy People 2030 definition of organizational health literacy. And they basically stated we cannot achieve health equity without addressing health literacy as well. So why am I talking about all those things? All of those things are things that align with your organization's mission. And that is another way to help get leadership engagement. And that leads to that second attribute about involving health literacy in planning, evaluation, and improvement across the organization, not just in a corner, not just in a silo. The engaged workforce, the prepared workforce, absolutely. We have to figure out how to, I think we're doing a good job of investing in health profession students, a fair job. We're better than we were, but we have to make sure that that becomes part of the culture they enter into when they leave their training, and that every single member of the healthcare team, clinical and non-clinical, understands the importance of clear communication and making sure people understand, including consumers. And that means people with health conditions, people who have certain conditions, people who don't read well, people who may read fine, different populations, but making sure that they're involved up front and not just after the fact when we're ready to roll out some new thing and say, isn't this wonderful? That we meet the needs of everyone, regardless of the venue that we're talking about, that we have navigation and accessibility that are, sorry, I have to fix my screen, that meet the needs of everyone without stigma. effective communication, and that's where so much of our universal precautions, our plain language, our teach back, verifying and making sure people understand is so important. Why do we come to work every day if we don't really make sure that people have what they need at the end of that day to care for themselves or their loved ones? And then specifically focusing these kinds of interventions on people in higher risk situations, whether it's transfers or discharge, medication adjustments, tough diagnoses, et cetera. And easy to use materials. Historically, that's been a major part, a major focus of health literacy. So getting materials that are in plain language, in multiple languages, and us making sure that we explain coverage and cost. So trying to wrap your arms around these attributes, prioritizing 1 or 2 or 3, you can't work on all of them at once, but this gives a framework and it gives you some evidence and some ideas for where to start and how to start to make it part of your organization's culture. So we know, again, so we've got that framework. We also know that we've got a variety of really good, strong health literacy practices. We start with the universal communications principles, meaning that any of us can experience limited health literacy depending on the circumstances. So we don't have to have this special kind of talking to certain people because it's much more efficient and effective to use these principles for everyone, with everyone. We've got superb resources like the cultural and linguistically appropriate service standards from the Office of Minority Health that help us with language access and ensuring that we're adhering to not just the letter of the law, but the spirit of the law to make sure we're addressing new populations and people who may struggle with languages in many different settings. Use of plain language, we talked about reader-friendly materials, we talked about making sure people understand and accessibility. So we have a whole array of practices, tools, features. I appreciate Cindy Brock entering those in our chat. The HARC, the Agency for Healthcare Research and Quality, has a lot of great resources to help support deploying and using these practices. And thinking again, where do you integrate? Where do you build these into your health setting? And these health settings apply whether you're public health, clinical health, et cetera. All of us should be, if we're not already, thinking strongly about how do we reduce disparities and promote health equity in everything that we do. We're always training and educating people. How do we weave health literacy into that? Fundamental to quality care, to patient safety. Starting to look more critically and curiously at how health literacy, health communication between providers and patients or families may go awry, not just communication between providers. Lots of issues with accreditation, regulation, and risk management. That may be another place to gain traction. And the business case. Clearly, we do need more work on establishing what is that business case. And that business case may align with mission. It's not always going to be a dollar for dollar reflection. There are lots of incentives for achieving outcomes and processes that can be impacted and improved by introducing health literacy into those, like reducing readmissions, patient experience, all of those areas as well. So with that kind of overview, it clearly applies everywhere. We've got a great set of practices. We've got a great framework. So we'd like you to kind of think about those things and spend a second or two kind of ranking what top 3 areas of the attributes do you think could help address those bigger health literacy issues that you just described in that previous question. So it may take you a minute to kind of ponder, but assuming you can only choose 3, which of those 10 do you think you would like to get started in? So
yeah, that's great. So we'll give people time to read through each one. There are 10 attributes. They can't all quite fit on the screen, but we will,
So I see they percolate up as they investigate. So 8 just moved up. Okay, good.
Yep.
And this,
yeah,
and this could be based on whether you think it's the most important or where you'll get the most bang for your buck, or whether you think it's low-hanging fruit to help you establish a foothold in making improvement. And then I think the rest of the sessions, when we talk about how do you evaluate this? How do you look at the effectiveness? How do we contribute to the literature in order to advance that part of the body of research? So lots of interest in leadership. And I always think of attribute 1 and 2 kind of woven together: planning, evaluation, safety, quality, and training the workforce. Don't feel compelled to focus just on the order of the attributes. You want to scroll down a little bit?
yep.
High risk care is not a bad area to start. Sometimes you can really illustrate the impact there.
Yeah, so I'll just give people some time to work their way through this.
I see a few people are interested in including consumers, which can sometimes sound daunting, but can be relative. You can make it as elaborate as you want. If you have a patient and family experience, advocacy, family or a family advisory council, those are helpful places to start. Asking a couple patients to take a look at something to help you improve it is another way to approach it. So don't be afraid to do that. They're the experts in what they need to know or do. So we've only got 14 people. Let's.
Yeah, we'll just wait. It's all good.
You have to ponder it a little bit.
Takes time to read through 10 things as well.
So they can't see the bottom 2, right? Unless you scroll down.
Yeah, I can scroll down.
Yeah, why don't we
They
again?
can see them on their screen where they're voting.
I see, okay. And interestingly, if you're thinking about leadership engagement, thinking about how you would do that, how are you going to engage your leaders? And if you're thinking about addressing health literacy at high risk points, what does that look like? Are there other attributes that are part of that? Lots of times folks tend to focus on easy to read materials, which is relatively straightforward, not easy, but I think it's easy for people to kind of grasp, especially when you can compare before and after. But we want to look at what makes a difference. Then you want to look at how does that contribute to that health literate healthcare organization. So should we shoot for at least 25 people? That's about 50% response rate. Or
yeah, it's just interesting that you know, the top 3 right now are really sort of high up, you know, at the top of the food chain per se, rather than at the level of the actual person who's using the healthcare service. in terms of what people here seem to think are their biggest health literacy issues in their organization. So is that that people are feeling that they're doing the other attributes super well in terms of with their actual patient population, but that the management and up the hierarchical organizational things is where they're falling? Or are they feeling that they can't get those other attributes at the level of the patient until they get the engagement and the integration and the workforce preparation?
Yeah, and then that, resistance was high on that earlier list, and it was that
Right.
usually the resistance is from the folks in the trenches. I don't have enough time to use these skills. We're so busy. I wonder maybe if the resistance was more a reflection of feeling like they didn't have the leadership support that they are interested or felt like they need or do need. And there's some of that influenced by the time of the COVID times as well. I chose QI and high risk points because we need the success stories and ROI data. Absolutely. I think one of the ways you want to support leadership with data, but also the success stories and the opportunities within your setting to help make that difference, to generate more evidence that this is important and valuable work, I would say.
Super.
All
All right.
right.
It doesn't look like anyone else is actively on that poll, so we can probably move on.
All right. I think you're up next, Beth.
Thanks, Marianne. So yes, I'm up next. And as I mentioned before, I'm Beth Mansfield, and I'm here from Health Canada. And what I wanted to talk about today was how we've been trying to apply a health literacy lens in the work that we do in our knowledge translation and exchange unit, which involves nutrition labeling. So we're the group that's responsible for developing sort of policies and regulations related to labeling of foods. And one of the things that I noticed when I first started to work at Health Canada about 10 years ago, I think it is now, is that when I looked at the regulatory, what we call an impact assessment statement for nutrition labeling, it said that, the overall goals and objectives of nutrition labeling were to ensure that an average consumer would be able to use nutrition labeling to make an informed choice. And I sat there and I said, well, what the heck is an average consumer? Canada is ethnically very diverse. We're a bilingual country. We have Indigenous populations. We're geographically super diverse. There is no average consumer. And the Public Health Agency of Canada, which is another agency that works alongside Health Canada and the Government of Canada, had been really doing the seminal work in health literacy in Canada back a number of years ago. And unfortunately, their funding disappeared. But I was able to take their health literacy work and really apply it in the context of what are we actually doing to make sure that Canadians are able to more easily access nutrition label information, to be able to understand it, to be able to compare and evaluate it, and really apply this information to make safe food choices. So we've got, food safety issues, as well as healthier food choices for themselves and their families, which really, when you're applying this, which is basically a model of health literacy within the determinants of a health context, this is going to contribute to a healthy population. So what we looked at doing was to systematically integrate a health literacy lens into the work that we were doing with consumers to help advance from beyond the individual to at the population level, to make sure that what we were going to be going ahead with would not only work with consumers' knowledge, competence, and motivation, and their individual capacities to notice the label information, understand, appraise, and be able to apply it in the context of their own dietary goals and goals and needs, but that the labeling approach would also, under that health literacy lens, provide very quick but easy guidance for all people living in Canada about things such as nutrients to limit. You know, we have a really big focus on right now front of pack labeling for nutrients that are high in sodium, sugar, and saturated fat. And all the research, consumer research that we did with a health literacy lens was helping move this policy and regulation forward. But that, you know, part of that health literacy lens was not just looking at the individual consumer competencies and the labeling approaches, which would work across the diversity in the Canadian population, but we also wanted it to be a nudge for food industry to nudge innovation and reformulation so that we could encourage the availability of more accessibility to foods with lower levels of key nutrients of concern. And that overall, that would give us dietary guidance that would nudge patterns of eating for overall nutritional health and well-being. So this model that we used was actually derived from a conceptual framework that Christine Sorensen, who is our next panelist, developed as part of her, I believe it was your PhD work, if I'm not mistaken, Christine. And she allowed us to sort of to adapt this, to use it in the context of food and nutrition. And one of the things that we then did is, in order to be able to apply this actual lens at the federal level, we needed to make sure that we had a way to apply these consumer competencies. So we actually worked with Barry Weiss's newest vital sign screening tool, and we adapted it as a way to assess risks of limited and marginal inadequate health literacy in the Canadian population using our bilingual nutrition facts table. And the newest vital sign, as you know, you're all very well aware of, uses a nutrition facts table on a container of ice cream. It looks at prose literacy, numeracy, and people's ability to go and find information on that label and then be able to use it and evaluate it and make decisions that might involve some math, et cetera, to be able to answer 6 questions correctly. And it was a very simple tool with a visual element that we included voiceovers on top of, and we integrated this screening tool into all the research that we did with consumers from the perspective of making sure that we could always make sure that we had participation rates by health literacy level that reflected the last measured health literacy status of the Canadian population, which was 60% of Canadians were at risk of limited or marginal health literacy. We also were able to then use that to get participants by levels of health literacy level to help us reframe and reword our research ethics board submissions from the perspective of consent forms. And the research ethics board were, you know, floored that finally somebody was coming in, taking these very complex consent forms and putting them in very plain language in a way that was, you know, simple and easy for people of all peoples living in Canada to be able to understand, so that they knew that, you know, what they were signing up for and what they were consenting to. And that in of itself was a huge process, but gave us these much more plain language consent forms that were much easier to use. So that was one of the, you know, research tool developments that we used it for, but we use it for many different research tools where we could pilot test with people of varying levels of health literacy to make sure that the tools and the methodological approaches that we were potentially using in consumer research could be understood and used by not only people with adequate health literacy, but again, those at risk of limited or marginal. And one of the interesting things that, you know, we did from the perspective of consumer discussion groups is that we always made sure that to minimize stigmatization, you know, if people were more disadvantaged by limited risk of limited health literacy, they were in groups together, and those with adequate health literacy were in their own groups, so that we could have better, promote better conversation, participation, and discussion, and minimize stigmatization. We also did all our qualitative coding in terms of qualitative research by competencies of health literacy, so that we were really trying to understand the research findings from the perspective of, accessibility, understanding, appraisal, as well as potential use of a labeling approach. And this was really interesting too in our quantitative research, because by having that 60-40 split in health literacy in our consumer research that was quantitative. So we did a lot of mock package trials that were online. So they would be plain language with voiceovers integrated into them, so people could listen to any question and any answers that they were being asked to provide, as well as being able to read them. There were lots of visuals where people were not asked what's a nutrition label, what's a nutrition facts table. They were asked to click on pieces of information, that they had accessed and used to be able to make a decision in things like mock package trials. And, even in our retail food lab research, again, we had objective measures as well as subjective measures by using things like eye tracking to then complement what people were telling us, and using storytelling as I work through to make a decision, what are the things that that people are thinking about. So all of these sort of health literacy implications, and making sure that we were always recruiting, sufficient part of our participant panels to be at risk of limited, marginal versus adequate, then really helped us understand quantitatively in a lot of the modeling that we did statistically, was to try and understand how health literacy of participants would moderate some of the findings around accessibility, understanding, and evaluation of labeling, so that we could really make sure that whatever approaches that we were going to go forward with from a policy and regulatory perspective, that it was meeting the needs of those who are the most disadvantaged, rather than, typically these consumer studies use market research panels, which are actually more than 80% of those participants have adequate health literacy. And we know that because we actually had to screen an entire consumer research panel of a marketing research firm to make sure that we could get that 60-40 split. And to their surprise, they were thinking that they easily had that 60-40 split. They didn't. They were more than 82% had adequate health literacy. So, it also helped us better understand the utility of some of these market research panels, and how you can actually move forward systematically with your research to really understand how to recruit, how to develop tools, and how to develop appropriate methodology and statistical analysis to really make sure that you're systematically integrating that health literacy lens. And that then really helps us really understand how health literacy has impacted upon consumer competencies in the context of food-based decisions. And we certainly published our work on that. And so I can let people know about that later on if they're interested. And I think that's what I wanted to let people know that we've done in terms of the systematic integration at the level of an organization to inform regulatory work. So I'd like to now move it over to Christine Sorensen, who I believe you're in Taiwan right now. Is that right?
Yes, thank you very much, Beth and everyone, and thank you for the invitation to join the session here. I am attending two conferences this week, HARC here online, and then in the next couple of days, we will have the Asian Health Literacy conference, which is a hybrid conference. So if anyone wants to have more than HARC conference this week, please sign up also for the Asian one. The agenda is as exciting as this one. And we're discussing the same topics as you mentioned, Barry, and as everyone mentioned here in Slido. So what is great for me to see is that it's really becoming a global agenda now, and a global movement, global community where we can learn from each other and move the barriers and try to lead where we will go next. So Beth, maybe you can change the slide to the next one.
Yep.
So what I wanted to share with you today is the systems capacity model for health literacy, because while it's great, we've been looking at individual perspectives and organizational perspectives, we also know that we're all part of a wider ecosystem. And I think that's where we need to dive into the more complex matters of health literacy. So I was studying system thinking models and found one that really resembled much of the work we have already done, which we have discussed and highlighted today, namely the work internally in organizations about health literacy being part of a vision and a mission of an organization, really as regarded an asset for the work that an organization is doing, and therefore also training their staff in having those skills, as you mentioned, Marianne. But it's also about building the bridges to our educational system. So not working in isolation in healthcare, but really try to bridge also education systems so that health literacy is integrated as part of curricula of healthcare professionals, but also for teachers, for example, or people working in sport and well-being, because health literacy is part of the whole health spectrum, from health protection to healthcare to disease prevention to health promotion and well-being. And for each of those areas, we have different disciplines and different professionals. And health literacy is a cross-cutting topic that goes that fits into many different professional development skills. So let's see how we can bridge to other sectors, bridge to other disciplines, and get health literacy in there. And that leads then also to the need for partnerships. So we have seen across the world that in many countries now, organizations have started to build partnerships and coalitions to actually try to make that political change that we need to get health literacy into the political agenda. And we did see that US, back in the days with the Obama administration, that you were leading the way with one of the first national action plans on health literacy, and that served as an example for many countries to follow. And from a systems perspective, we also see that we need the data, as we discussed at the start of this session, but not only project-based coincident data that we want, that we think it's nice to know. We need to know health literacy data and similar data that support the health literacy insights. So what I'm trying to advocate for now is really that we create health literacy dashboards at governmental level, organizational levels, maybe municipalities and communities, where we have a stream of data that are related to health literacy and health and well-being overall, so that we get much better picture of what is at stake in each setting or each organization or in each community. Because only if we have sufficient data and sustainable data and really a monitoring system, we are able to generate insights that are really helpful, that can predict what way it's going and how we can design new interventions. And that requires a whole other setup than making some research projects only. And what of you have seen today published in PubMed, that's single projects, and they have a start and they have a stop. It's a project. So we really want now, I think, to push the development so that we make health literacy sustainable. And that goes back to having the leadership, which we discussed. We need health literacy champions that dare to speak up and dare to go against the resistance and argue and explain why health literacy is needed as a leadership skill. And then we need to argue also that we need to have the funding, but also that we actually create funding, because by investing in health literacy, people are able to make other choices, staff is able to make other choices, and we will have more maybe lean organizations, or at least we know that many will be saved from having a lot of detours in the healthcare system, or coming again and again and again. So it's not only a burden, it's really an asset, and we need to be brave enough and have clarity enough to take those discussions and bring in even more people from health economics to build that business case, Marianne, that you also mentioned in your presentation. And then there's a lot of talk about digital health literacy. We know that the technological advancements are expanding and they're accelerating, and it's difficult for many to join, but we see that problem and challenge also among ourselves and our staff. So therefore, the digital and technological aspect needs to be part of our discussions. And lastly, the people-centered approaches, because this is really about people, and people are living health outside our organizations, and that's why the system approach is so important. We need to know much more about how people live their lives, what are their health beliefs, what aspects influence their health choices. They may have the best knowledge in the world, but may not be able to go because there are other barriers, system barriers that prevent them to join the services that we have set up for them. And we need more insights on the service design and the journeys that people are taking from the start at home to they actually make that encounter with staff and going back again and implying it into their real lives. And I miss that in a lot of our research, that people live their lives with health and well-being, and they just want to have, flourishing lives where they can have a job, sustain their families, have time with their friends and families. And that's a very different discourse than the research jargon that we often use in our interventions. So we need somehow also to build that bridge between the lived life and our way of thinking as experts. And I truly believe taking on that system thinking will help us push the developments in a direction where we can learn much more and become much wiser in what kind of support can we design for people to live healthier lives. So with this, I hope that we will hear some advice from our colleagues here joining the chat and the session today. We are happy to hear your thinking on how can we expand the system thinking with relations to health literacy. Thank you. Over to you, Beth.
Thanks so much, Christine. So let's do a little bit of just a recap, and then we can go on with a bit of a discussion. So Barry Weiss, he spoke about the need to change the focus of health literacy research and the need for research showing that making hospitals and health systems more responsive to health literacy issues will make patients healthier, result in fewer admissions and readmissions, and reduce healthcare costs. Marianne discussed how leaders can advance their institutions toward becoming health literate healthcare organizations by identifying how health literacy informed strategies align with and support their missions, and implementing and evaluating practices, policies, and indicators to support such alignment can promote equity, quality, safety, and patient-centered care, can contribute to and accelerate evolving research on real-world health literacy-focused implementation. I spoke to the systematic integration of health literacy considerations at the government level into social science and consumer behavior research. So really at the population health level to better meet the needs of the increasingly diverse Canadian population. And Christine addressed the need for a real systematic approach to bridge health literacy as a public health challenge that can't be neglected. And this requires, political buy-in, development of health literacy capacity at not only micro and meso, but also macro levels. So let's, to get the conversation going, how about everybody just introducing yourself by your role, just so that we can get a sense of what are the dynamics of the group that are here today? Are we mainly educators? Are we a mix of educators, researchers, policymakers? Are we clinicians, administrators? So if you could go on to the Slido and just put a word in to describe yourself by your role, that would be super. And then as we wait for everybody to do that, just some information about how to move forward with the discussion. So you can put things into the chat and we can address them. You can go into the question and answer. We can address them there. You can also put up your hand, and we do have a person here who's in the background who, if you put up your hand, they can let you be unmuted and be able to speak if you'd like to ask your question or contribute to the discussion with some input. So it looks like we're getting a lot of nursing and researcher, but again, quite a diverse set of roles I think I'm seeing here. I can see Christine nodding her head going, yeah.
I
So
think
some
this is
health
really
literacy.
great, and it shows the variety of disciplines involved, and we have to be careful not to simplify too much, because every role and discipline has its own needs for specific skills, because in specific settings with different target groups, of course.
I only see a few people who are health system administrators. And again, that thing about start from the top and work down, we need to get those folks turned on to this issue.
Well, remember too, the word cloud, the bigger the word is, the more there are. So administrator is actually a large one here.
Okay.
Yeah. Yeah. So administrators, people in nursing, educators, and health literacy actual specialists. So
Also, it's been interesting to work, as you say, Beth, with in the political setting with decision makers and policy makers. And interestingly, I've been working with the Council of Europe. It's a member organization with more than 50 countries in Europe, so much larger than the EU. And one of their key messages is on human rights and how to make sustainable living in the European region. So they are linking now health literacy to the discussion about human rights, which I think has been also it's levering the discussions. It's not only health access to health, but also access to the knowledge that you can and ability to act, which is what health literacy is about.
One of the things we didn't talk about, I didn't hear anybody mention patient navigators. You know, when patients are in the hospital with a serious illness, they have somebody assigned to them to kind of be with them and walk them through and explain what's going on. And at that hospital association meeting I spoke at a couple of months ago, someone brought up a paper that was in one of the cardiology journals where they had I guess American Cardiology, whatever it is, ACC has a scoring system for people with heart problems who are at risk of readmission. And they targeted all those people who scored risk of readmission, assigned them a patient navigator, and kept track of a before and after thing. And they reduced the rates of readmission by 30% by having people have somebody personally work with them. You know, and that's a
patient
health
care
system
advocate.
change.
Yeah.
But it was really interesting, I thought.
Well, let's move on to, so we can see that we have quite a diverse group here today. And thanks so much to everybody for letting us know who you are by your role. What we wanted to do was to move forward with a little bit of a discussion, sort of in a sense, like where are we at in the stages of behavior change with health literacy. And the first question we wanted to talk about with you is, what do you think could help you address your biggest health literacy challenges in your organization? So again, you can contribute by putting it in the chat. If you would like to speak, put your hand up and Mario will open up your microphone for you. So I can see that Karen had said that they'd had a patient navigator for some time, which was extremely helpful, but it was one of the first things that was a cut in terms of position when they had a round of layoffs.
And then And that's even though there's evidence having patient navigators reduces readmissions and so forth. So that's crazy. I once went to have a tooth pulled, and I had the oral surgeon had patient navigators. You know, somebody comes, the dentist says, I'm going to take some pictures of your teeth now. And this person says, he's going to take, well, I'm going to take x-rays of your teeth. And she says, he's going to take pictures. And she explains all the words, you know, and it was really amazing, you know. And, you know, I didn't really need that. I understood what x-rays were, but you really saw how there's, you know, it's like, okay, this health professional doesn't know how to talk normal English, but we'll assign some person who will translate for the patient. And it was actually pretty impressive, you know.
But it's also here, Barry, again, an example where in my country, Denmark, I was in a hospital and it was volunteers from Red Cross. So it doesn't have to be someone
Salary.
hired in the organization. We can make coalitions and work with other organizations and partner up. And there are so many that really would like to contribute, and they can be trained and help. So these are great.
Yeah.
And
So I can
Barry,
see
that was
that
an example of using universal precautions, right? We're not even, I mean, for all they know, you could be really stressed out when you go to the dentist. So they were addressing your potential communication concerns.
So I can see that in the, Deneen had said that looking at what could help you address your biggest health literacy concerns in your or issues to continued vested interest by nursing executive leadership. I'm not seeing any hands up or many chats, but you know, thinking about sort of where we're at in the behavior change in our organization. So what do you think could help address your biggest health literacy issues? Thinking about those 10 attributes of a health literate organization, where can you get started towards advancing as a health literate organization? You know, and what steps do you think you could potentially take? And then even thinking from a, you know, a maintenance perspective, how do you make that stick? How do you make it last? How can you sustain it? So really looking at
the comment here about we should raise awareness of health literacy in organizations. The question is, how do you do that? How do you do that and really make a difference?
Well, and it's interesting, like I can comment a little bit from, you know, from the perspective of what we've done in terms of raising awareness of health literacy by using the words awareness, accessibility, understanding, evaluation / appraisal, and communication / use all the time, over and over in all the work we do with consumer behavior research. It became the common vernacular. And then we have to report analytically with sex and gender and intersectionality of which health literacy is. It spans across gender, sex, culture, ethnicity, socioeconomic status, etc. So it was a huge deliverable under the sex and gender-based plus analytical framework that we need to deliver all policy and regulations under. So by always having that health literacy lens integrated in, that was meeting a lot of requirements that we have as a government are required to do. And it was also allowing us to position, you know, our consumer research in a way to say that if the most disadvantaged amongst us are able to use this regulation to be able to make healthier food choices, and we can show it in our research, we have a much bigger leg to stand on, you know, to combat, for instance, industry not wanting to, you know, go ahead with, for instance, a warning label on foods. And so by really incorporating health literacy in and always speaking to it and always making sure that it's at the forefront of every conversation, you know, around the development of the research that you're doing and the implementation and the evaluation, that's been something that's really helped make it stick and make it last and is sustaining that health literacy lens in the work that we do in policy and regulations around food labeling.
Beth, I agree with you. That's so powerful. And then if you can identify a handful of stories from the setting that you're operating in, not just something you've heard from elsewhere, to say, oh yeah, and this affects our organization, the people we take care of, the people we're serving. So puts that face on it. It makes the data humanistic, and it can resonate with leadership, especially, and other members of the healthcare team.
Yeah, and I think that's kind of Gary sort of saying to Barry's question, or for organizations that empower individuals, a bottom-up grassroots approach can work. And I think, that's what we've been doing. It's really a grassroots approach from the perspective of within the government, to really promote this health literacy in one perspective of the work we're doing. But it's, now we can move out and, spread our wings a little bit further. But what's super interesting is that what we noticed in our research at those that were the most disadvantaged from the perspective of nutrition labeling, some of them, made up for it by being extremely motivated, by being engaged and reading everything on the label, but reading it all and interpreting it completely incorrectly. And so feeling, that they were very knowledgeable when in fact they weren't, but yet they were highly motivated. And so knowing that what they were misunderstanding could be better, we could improve how we're providing that information. I mean, this is what really helped us.
Right, there's somebody raised their hand to speak. Andrea?
Yeah, hi. Thanks for calling me out. I'm Andrea
Tell us who you are.
Morrison. Yeah. I'm a peds emergency medicine physician. I'm at Children's Wisconsin, Medical College of Wisconsin in Milwaukee. So I've been in the health literacy field for quite a number of years and worked as an advocate at our hospital on our health literacy task force, and worked to spread the message for a long time and engage leadership. And a couple of years ago, finally did get a position as a medical director of health literacy. So I just wanted to share a little bit of the story of how we engaged leadership and how it's worked but not worked. So we spent a lot of time, and I say we, so myself, and then I have a co-director of our health literacy task force who's a nurse, and a safety specialist in our safety department. And her and I have been co-leading the task force, the health literacy task force, for like 9 years together. So her and I spoke at leadership forums, spoke to, our VP levels. We spoke wherever anybody would take us. I did a number of pediatric grand rounds. We did nursing grand rounds. We had, and like nursing grand rounds one year, we had a number of different patients and families come in. So we just spread the message wherever we could. We've had grassroots health literacy group here since 2006. And the grassroots original effort was educating groups of nursing staff and those like that, and groups like that. And so there's been some kind of longer term grassroots effort, but the leadership has never, really engaged with that. So, but that is, talking isn't actually what did it. And sadly, all the data wasn't what did it. We had to have local data, and we had to have the local data that they would listen to. And so we evaluated our safety stories, and that's what they listened, our safety events, and that's what they listened to, was when we had that local data, and the safety spoke for our hospital. And I think it's whatever speaks for your hospital is what is kind of what really, or for your organization, is what actually works. And safety is what worked for us, but I think equity can work for other places. And we've honestly moved around and engaged with whatever our organization is engaged in, because that's how we have to work. We are not a standalone piece of our organization. We kind of have to work with whatever our organization is working on, which is fine. That means we're working on what our organization wants us to work on. But I still think we need to continue to engage leadership constantly.
I agree.
Can I, Christine, thank you, Andrea. I think that's such, your work and what you've achieved and are achieving is really spectacular. And I was also intrigued, Christine, when you talked about the dashboard across all kinds of organizations and entities at the system level. Have you pondered what elements would be on that dashboard?
I think that is where we need to learn what kind of data do you as an organization already collect, so we're not reinventing the wheel, and what can be added that makes sense for that particular organization and the clients or customers, consumers that an organization work with, or a community, or even a government. Many of the organizations I know of in Europe, for example, they collect also patient satisfaction data, for example, which also makes a lot of sense. So I think that a lot of data already exist that can help us get an understanding of people's health literacy levels or insights. And also we know that from our health literacy toolshed that there are more than 200 tools available, and so every organization can have a look and see which ones they want to apply, and also that fits to their monitoring systems and funding, first of all. But I do see a big gap between what we measure and what kind of data insights we need. So I hope this will be a discussion for the next HARC conference, and also that we discuss it in the International Health Literacy Association. And I encourage everyone to become member to also continue the discussion after this session today. Thank you for your question.
Yeah, and maybe, identifying what's the mission and vision and strategy, what measures do we pay attention to for those reasons with our alignment. And then, oh, by the way, these are health literacy assessments, like the work that Andre Morrison's doing. They're identifying their safety events related to health literacy and patient experience related to health literacy, things that don't require.
Yeah, I think we are sometimes doing it already.
Yeah, and changing the perspective of that can help with a lot of that, hopefully, with that leadership engagement. Great.
Sometimes it's called a revolution, sometimes an evolution, and it also depends how far an organization is diving into all these matters. But for leadership to buy in, it's very often also what do they do already and that they can continue, or what are there a few things they need to start up to make it maybe more simple for them as well to join the journey.
And go back to this beautiful visual that Beth has put up, where we may be up there on action and maintenance, or action, and the leader may still be at pre-contemplation. So a lot of alignment.
So just to, before we finish up, just to make sure that, I understand what you were saying, Christine, are you suggesting that there's a lot of administrative data that's already being collected that could actually help, help us understand health literacy levels? We're just not accessing that data and putting it into potentially a format, or as you're saying, a dashboard, so that we can massage that to better understand what it can tell us. It's not about necessarily having to go and figure out how to assess health literacy across a population, which is very expensive and time consuming, but there could be these other administrative data that could actually give us am I understanding you correctly?
I think for example, the population data is relevant for government, and I would love to see them doing that every 3 or 4 years or whatever, so that we can, use the data to see a trend. Right. But at organization level, it might be other types of health literacy data, other types of tools we want to use, and so because most organizations are data driven one way or another. So it's good to look at health literacy, not in isolation, but as part of that data package and the dashboard that they already have. And also to see what kind of data are necessary at unit level or department level or organizational level, so that it can be an evidence-based organization or evidence-based policies that we want to design, and evidence-based interventions eventually. So all the data are there, and so getting it all together, that's what we could work on as part of the future research agenda.
Thanks so much. Well, it's 1 o'clock. We're at the end of our session. So I would just like to thank our our panelists for being here and sharing your wisdom and knowledge with us. And thank you so much, everybody who participated. We hope this encourages you to move forward in the challenge of getting health literacy as a systematic integration in your organization, as well as in the work that you do.
Yeah, fantastic. Great to see you all. And Christine, please bring warm regards out to the group in Taiwan. I messaged out to Peter, but there's nothing like if you would be our emissary to give him a nice hello. And thank you for everybody and fantastic discussion and great panel. There's a bit of a break, half-hour break. Please check out the posters and join us again if you might. If you can, please, the next session, 1:30 Eastern, a half hour. Thank you so much.
Thank you. And likewise, Michael, there is a greeting going out to you as well from here. So
Sounds good. All right.
Thanks, everyone. Bye-bye.
thank you. Bye.